Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm one of your co-hosts for the IFOMPT podcast. It is my pleasure to bring to you another wonderful interview. Our guest today is Dr. Julia Treleaven. In addition to being a part-time clinician, Dr. Treleaven is both a lecturer and researcher at the University of Queensland in Australia. She has been researching whiplash and neck pain since 2000, and in 2004 completed a PhD focusing on the neck's influence on sensory motor control. She has continued her research in this area and is now also looking at the role of neck dysfunction in those with headache, dizziness, and post-concussion due to concomitant whiplash-type injury. Dr. Treleaven has over 100 publications in this area and has written several book chapters. She is also a co-author of the recent book, Management of Neck Disorders, an Evidence-Based Approach. We've invited Dr. Treleaven to the show today for a new kind of interview for the podcast. Today we're going to be talking about a recent IFOMPT webinar that she gave. This is our first ever conversation about an IFOMPT webinar, but I hope we can have more in the future. The title of this particular webinar, which you'll find a link to in the show notes, was The Role of the Musculoskeletal Physiotherapist in the Management of Post-Concussion Syndrome. I attended the webinar and highly recommend it to anyone interested in this area of clinical practice. All you have to do is follow the link in the show notes or go to the IFOMPT website and you'll find it listed with their other associated webinars. And with that as our general introduction, let's get to the interview. Dr. Treleaven, welcome to the podcast. How are you doing today?
Good, thank you. Thank you for having me.
You're very welcome, and as a matter of fact, we are very excited to have you here today. You are our first ever IFOMPT webinar guest. And to dive right in, I would like to start by asking you, in a broad sense, what is the role of a physiotherapist when it comes to concussion rehab?
So I guess it depends what you're talking about. There's obviously the immediate acute sort of on-field and immediately after, but my area's probably been more in the actual rehabilitation side. So when people are still wanting to get back to sport and be cleared for that, or they have symptoms and they're wanting to improve from that perspective. So when you're talking from that perspective, then I think our role is to certainly screen for a lot of the potential things that could occur after a concussion that could be causing symptoms or causing some impairments. And that can be, some people don't report symptoms, but they still might have some impairments. And so that's an important thing that we need to be able to screen for these things. The thing with concussion is that it's really more a mechanism of injury. It doesn't actually tell you where the symptoms potentially are coming from. So, we need to be able to screen for the vestibular system, the peripheral and the central. We need to be able to screen for ocular motor function and the visual system. Certainly the cervical spine, musculoskeletal and sensory motor components could be affected from a concussion as well. And then there's also some physiological or autonomic nervous system dysfunction that can occur as part of a concussion as well. And then there's also some psychological changes that can occur in response to the injury as well. So I think it's important that we screen for that. Where we're able to, we can certainly manage each of those impairments and those systems. Some perhaps, musculoskeletal, obviously we're going to be better with the musculoskeletal side. We should be able to manage the physiological side, and we can talk about that. And then we should be able to screen for vestibular, ocular, and the visual system. But if we need to refer on to a vestibular physiotherapist or a behavioural optometrist, then we could do that. And so our role is also to be able to screen and refer on when we feel that it's out of our scope. And then also, I think, being sort of the case manager. So often if people have got really persistent symptoms that are potentially coming from a number of causes that are interacting, we often become the case managers. So where we're sort of really helping them to navigate the healthcare system and be able to find the appropriate people and to help them to manage their condition.
That's an excellent answer, and thank you for pointing out that sometimes for some physios, this even starts with on-the-field management. To speak to that for a moment, yeah, I was mostly referring to in more of an outpatient setting, so I just love how you dove into that. And one of the things I'm thinking about as I listen to you describe the role of the physiotherapist in concussion rehab is, are there any patients who don't need to be screened by a physiotherapist, or is this the type of situation where every patient who has suffered a concussion injury should be examined by a physiotherapist just to see if they need our services?
Yeah, I guess it probably depends on where in the world you are. So certainly athletic trainers that you have in America, I'm not sure about Canada, they often are trained to be able to screen for things. So certainly they will conduct the VOMS assessment, the vestibular oculomotor assessment. They can also do the Buffalo concussion treadmill test and things like that. And I think they are trained to certainly screen for perhaps some cervical musculoskeletal things and that sort of thing as well. So I think if they're not presenting with any specific symptoms, and it's more just to screen for some impairments and to say that they can return, they may not. But we certainly do know that there are some impairments that are persistent, even in that a subacute phase in people who say that they've recovered. So it is good that if they are doing that, that they are trained to be able to look at balance system and the vestibular ocular system, and also be able to screen for any sort of neck dysfunction as well.
So, a couple of times now you've already mentioned these different categories of symptoms. Can you dive into that just a little bit further and give our audience an idea of what some of the symptoms and problems are that a patient with a concussion can experience for these different types of categories?
So I guess that is where there is a bit of a problem, because so many of the symptoms can overlap. So you have common symptoms such as headache, fatigue, dizziness, visual disturbances, brain fog, sleep disorders, all that sort of thing. And unfortunately, if you think about people who have a whiplash injury, for example, they can report headache, dizziness, visual disturbances, fatigue, etc. So just sometimes the symptoms by themselves are not particularly helpful, but certainly there are some perhaps things that might make you think more one thing than another. For example, if it's more relating to exertional intolerance and the autonomic nervous system dysfunction, then they can still report all of those symptoms, but the symptoms will be brought on when they exert themselves. They might be brought on when they are trying to concentrate, those sorts of things, because it's that altered blood flow to the brain and changes in the way that the heart's regulated. When it's peripheral vestibular, for example, and it might be something like BPPV, then obviously they're going to present with very discrete attacks of dizziness and true vertigo and things like that. So unfortunately, the symptoms by themselves, not that helpful, but that's where it's important that we can do a good interview and assessment to try and work out which of those systems we think are causing the symptoms.
I love how you pointed that out. And of course, symptoms aren't 100% diagnostic. That's something we always have to keep in mind to make sure that we're matching up what the patient describes as their experience with the findings of our more objective exam. And speaking of that, can you give us some examples? And I know in the webinar there was way too much for us to talk about here, which is precisely why people should go and find the webinar. But can you give us some examples of the testing that you perform when you're trying to figure out which symptoms are at play with a patient who has suffered a concussion?
If you're trying to look at, say, for example, that autonomic nervous system, then the Buffalo concussion treadmill test, or you can use a bike test as well, can be useful, and you're looking for some increase in symptoms, significant increase in symptoms while they're doing that graded test. So that's a useful test. From a cervical musculoskeletal point of view, then obviously a manual examination, looking at range of motion, manual examination on muscle function. is useful to be able to try and put together a pattern of behaviour that you would expect in someone who has cervical disorder, but as well as sensory motor relating to the neck. So some tests that I would do there would be things like joint position sense or joint position error, so being able to relocate the head back to that neutral position with the eyes closed, using the smooth pursuit neck torsion test, so looking at the ability of the person to follow a moving target with their eyes while their head's still, and then compare that to when their head's kept in that neutral position, but the trunk and shoulders are rotated so that the neck's in a relative rotated position. We call that the torsion position. And then we repeat that smooth pursuit test. And if we're seeing a worse performance in that we're seeing more catch-up saccades and any complaints of dizziness or symptoms, then that would indicate that the neck is influencing that eye movement control if it's worse in the torsion positions compared to that neutral position. And then we can also use things like a trunk head coordination test where we're looking to see whether the person can keep their head still while they rotate their trunk. And if that brought on symptoms, then that would, be less likely that that's a vestibular issue because the head's still and might more implicate the cervical spine. So there's a few sort of tests like that we can do. And obviously then there's your vestibular ocular motor screen and other vestibular tests that you might want to do as part of that as well.
I suspect that some of that made a lot of sense to our audience, but of course the words are a little harder to follow than seeing it done in person. And I'd just like to take a moment and let the audience know that during the webinar, you had such amazing videos that you played through, I suppose it was a PowerPoint format, and it just really augmented the viewer's ability to absorb what you were describing during the webinar. It really was truly educational and visually rewarding.
Thank you.
And building off of that general conversation in terms of here are the things that we can utilize, testing, treatment, etc., you mentioned in a general sense manual therapy. What types of manual therapy are you either relying on or potentially avoiding with this group of patients?
Yeah, so I guess it's, obviously the manual therapy that you would use, as per whatever the patient has is their problem. We do our assessment and then we can direct our assessment accordingly. I'm Australian trained, so I tend to use, more Maitland-based things, but also some Mulligan type things, so snags and things like that. But certainly whatever you have at your disposal that you feel is suitable for the patient. Probably the thing that I would be careful about is upper cervical manipulation, because potentially we're dealing with a traumatic event and the potential for some hypermobility rather than hypomobility in that area. So that's something that I probably would not be directing towards. But certainly sometimes things like thoracic manipulation might be suitable to help with the control and movement and take strain off that upper cervical region. And that's where I think, in terms of your manual therapy, in conjunction with that, it's important that we're addressing the muscle system as well, because 80% of your stability of your neck is coming from your neck muscles. And so I think it's important that we're able to rehabilitate those as well.
So I'm guessing, as is the case with most things, you're doing this combination of the hands-on manual therapy treatment and then the hands-off exercise and muscle re-education component.
Yes, absolutely. So, yes, I think, often they do need some manual therapy, particularly if they've got pain, if they've got headaches that are cervicogenic. We know that that multimodal approach is beneficial. So, certainly the combination of manual therapy and exercise and our advice and education is going to be better than doing any of one of those things alone.
I think one of the strong suits of the webinar was that you very nicely, as you've already mentioned here as well, categorized all these different types or groups of symptoms. And you paid particular attention to identifying, or I guess teaching us that we need to identify all of those different relative roles and relationships. Can you speak to that process as it relates to clinical reasoning and why it's important for the physiotherapist to be able to examine and then subsequently treat all of these different types of categories of symptoms?
Yeah, so I guess the thing is that, everything's interrelated. So the neck is strongly related to the vestibular system and the visual system, probably more so the visual system. If you just put your fingers on your suboccipital muscles, for example, and just keep your head still but move your eyes left and right, you'll feel those suboccipital muscles firing away. So if somebody potentially has a problem with their visual system, then that could also impact on their cervical spine. So it might look like that it's the neck that's causing the symptoms, but it may actually be the visual system that's driving that. And so that's important to be able to recognize, because you would still treat the neck because it's being impacted by that visual system, and you can help with symptom relief and things like that. But until you address the visual system, it's going to keep coming back. With the vestibular system, for example, often people who have prolonged vestibular issues get stiff, sore necks because they're trying to limit the amount of vestibular input. So they may present with, stiffness and pain in their neck, but again, it's being driven by that vestibular system. You get other situations where if their vestibular system and visual system is not working very well, they need their neck to be working exceptionally well to be able to compensate for that. So I think it's being able to identify which is the main driver of the symptoms, and then what things are kind of secondary to that, and which way should you start, where should you start, and also knowing why you're treating something. So, for example, if you're treating the neck, are you treating it because you think it's the primary problem? Do you think it's a secondary problem? Do you think it's a trigger for something? That sort of thing, because that will help you to direct the rest of your management and to be able to prioritize things.
To perhaps put a little conclusion on that, to me, what I'm hearing you say is that we have to be both thorough and precise so that it allows us to be effective and efficient in the clinic, which is really how we create an ideal service, not only for us as professionals, but for our patients. If we want them to get better, we have to have this type of process that can identify what's going on with them and then, of course, teach us how to fix the patient.
Yes, definitely. I think that's exactly right. We really do need to be able to work out what we think is going on, clinically reasoning it. There will be some patients where they're going to have a mix of a few things going on at the same time. So they might have some vestibular and some neck and some visual and some physiological and a little bit of psychological in the mix as well. And you would be addressing all of those things at once, and they may or may not be interrelated. But certainly, I think being able to identify which systems might have some impairments. Sometimes the treatment may be similar. For example, if someone's got a vestibular ocular issue, then the treatment might be just doing what they can't do. So they're doing saccadic eye movements or smooth pursuit eye movements. But I think it still is important that we kind of understand those relationships to other systems so that we can make it more precise and more efficient.
And as you've already mentioned today, and you also bring this up, of course, in the webinar, of course, we as physiotherapists can't take care of everything ourselves with this type of patient population. So, what are those referrals that you're looking for? Who is it that you're potentially going to send one of these patients to?
Yeah, so we certainly know that in the interdisciplinary clinics that have, access to lots of different people, people with, significant persistent concussion symptoms do a lot better. So in the ideal world, it would be lovely to be able to have all of the people together, but that often doesn't happen. So I think it's important that you try to make some links with people that are in your area that you can refer to if needed. So in Australia, we call our behavioural optometrists. I'm not sure. I think you might call them vision therapists. Some other people call them different things. But sometimes it's important that we can identify whether the patient may need to be seen by a behavioural optometrist. You can use things like the Brain Injury Visual Symptoms Survey, and it asks questions about light sensitivity and double vision and reading and depth perception and things like that. So if they're scoring, more than say about 30 odd on that questionnaire, that may be a time to think about referring on to a behavioural optometrist for an assessment. While they'll do similar things to us in terms of some vision therapy type work, they certainly can prescribe some specific glasses and things like that that can help as well. And they certainly have much more sophisticated testing type things. I think it's also important to consider referring on to a vestibular physiotherapist, particularly if you feel that that is either out of your scope and you're not able to manage the sensory motor type deficits, or if you really feel that it perhaps is something more complicated in terms of that vestibular system that needs much more thorough assessment. Also, if your patient has significant headache disorder, it may be timely to refer them onto a neurologist or a medical professional who can manage that from that perspective. And certainly, if people have got persistent pain and those sorts of things, then you would be thinking about that. It's also important sometimes to be thinking about a psychologist if your patient's having a lot of distress or anxiety or even some, indications of some depression. And that can certainly happen. People can get changed mood states in association with their concussion, and that's quite common. But if that goes on and it becomes a thing that they're not able to manage, then it might be important to send them off to the psychologist for an opinion for assessment. And then obviously things like neuropsychology for assessments for cognitive function if you feel that that might be required. The other thing is sometimes things like using your athletic trainers. So you might have determined that they have a problem with exertion intolerance. And so it may be that, talking to the athletic trainer and particularly if they're a sports person, helping them to sort of so that they can still be going to their training and things like that. And the athletic trainer is able to supervise that and help them do it in a safe way. But they're still sort of in that environment and social environment of being in their sporting team and that sort of thing. Yeah, so I think there's certainly lots of scope for different professionals to be involved. And certainly there's also that scope of, considering some red flags and things like that, particularly being able to identify those and referring back to the medical professionals as well.
It's a really great picture that you paint of the potential for such a multidisciplinary team to work with patients that have suffered concussions. And it makes me want to ask the question as a follow-up, when you are implementing this general type of approach in the clinic, what type of results have you seen from your patients that are recovering from concussion injuries?
Yeah, so I think you definitely can see some absolutely fabulous results. Sometimes it's quite easy. So, you might have a patient who's been struggling with symptoms, struggling with work. Oh, that's the other thing I meant to mention too, was as other things that you need to consider in terms of that multidisciplinary is being able to talk to their workplace or their school, because that's where they might need modifications made and things like that. So it's an important thing to consider as well. But certainly, if they've more of the problem is that exercise intolerance and they can get on and train that in a sort of sub-maximal way, they can do very well. You also have the patients, for example, I had a fellow who was a physical education teacher who had, when he first came, he couldn't even look at his phone. He was so light sensitive. He had neck issues, had vestibular ocular issues as well. And, it did take about 4 months to get him back to work, but he was able to get back into that very busy environment that had lots of things. He had to be able to work at a computer. He had to be able to teach swimming classes and basketball and noisy and messy environments. And he did very, very well with the rehabilitation as well. So, you definitely will see really good results if you're able to work out what's going on, direct them to the right people and that sort of thing. It's sometimes hard in terms of some of this stuff the patient has to do. They have to do their exercises and they have to be motivated. And so if there are problems, particularly teenagers who feel very distracted from their social environment and that sort of thing, if they're not able to be at school as much as they would like or not able to participate in their sporting things, if they have got a problem with just that depressed mood and they're really not able to do their rehab, then that makes things a lot harder because, we don't have a magic wand and we can't do it for them. But certainly that's important to recognise too, so that they can get help so that they can then move forward.
That's such a great response, and I especially love how you point out that it can take a long time I find, for example, in the clinic that sometimes even if the patient starts off on the right track, they're doing the exercises, they're coming to therapy, etc., people really get sick of how long it takes for them to recover from this type of injury. And of course, they don't all take a long time, but I'm thinking of those patients where it's 3 months, it's 4 months, it's 6 months down the road, and they're ready cognitively to be better, but they're not necessarily healed enough to be better. So they're doing too much, they're stopping the exercises. I find in those situations, a lot of times I become just as much of a verbal coach as anything else, just trying to give them some realistic focus and maybe different tactics of being patient and just waiting and holding on and slowly seeing those good results roll in, which can be very difficult for them.
Absolutely. And, you do become a coach, you're coaching them, you're egging them on and, showing them, sometimes they can't see that they have improved. And so it's really showing them, oh, look at what you can do now that you couldn't do a month ago, that sort of thing. So I think, really directing them to focus on what they can do, what's better, what's improved over the week or the month or, whatever it is that the time frame that you're seeing them, that can be helpful because often they can sometimes lose sight of that on that day-to-day grind of what they're dealing with. The other thing I would mention too is sometimes it's hard for people who have post-traumatic headache, particularly if they've really got a significant migraine problem, and they can take a long time because it's really hard for them if they're suffering from significant headache every second day or so. Then it's very hard for them to do their exercises, to do, their vestibular and their oculomotor exercises and things like that. So in those situations, it's really important that they are getting the right help with, medication, preventatives, those sorts of things, try and manage their migraine as well.
Well, Dr. Treleaven, thank you for all of the wonderful work you've done, not just for our profession on this topic, but all of the related topics. And thank you for joining the podcast today. It has been both an honor and a pleasure to have you as a guest.
Oh, thank you so much. And I hope this is useful. And I think it's a fantastic area for physio. It really covers a lot of things that we can do and a lot of our scope. And so I think it's a really interesting area.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.